recording, and also let me say, before I do start the recording, that a couple housekeeping things. If you have questions, you have a couple of options. You can type your question into the chat box, just clicking on the little chat button at the bottom of your screen. Or you can also go into the Q&A button, type your question there, or simply raise your hand and we can sort of promote you to being visible to others in order to pose your question. I also want to acknowledge a participant that's on the session today, and that's Ruth Fetter, who is now on staff at Buddha, but was the executive director at the Mental Health Association, and it was the driving force behind the Mental Health Association founding the Parity Initiative. So welcome, Ruth. We're glad you're here today. And I, with that, am going to.
Just gonna now, yeah, the little. We should be good now. All right.
Sorry.
Yeah. So just as a quick kind of intro to this, this training is kind of for everyone, but just some of the few circumstances where this is really going to potentially speak to some of the work we're doing is if you or someone that you care about has ever had health insurance that didn't cover behavioral health or substance use disorder at all. If you or someone you care about has ever had trouble getting insurance to cover your behavioral health needs. If you've ever felt like your health insurer was treating your behavioral health needs differently from your physical health needs. If you are a behavioral health provider who feels like insurers have asked you to jump through hoops not required of your medical and surgical provider colleagues. If you've had trouble finding a behavioral health or substance use disorder provider who takes your insurance, or if you've ever suspected that a health insurer was violating mental health parity rules. Now, this training we've given in person many times. And for this slide, we would always kind of ask people to raise their hand if any of these things had happened to them. And you'd look around by the end of the slide and see that everyone had their hand in the air. These are common occurrences. These are not things that are only happening in certain sectors of the behavioral health world. This happens to pretty much anyone who has been in this, in either accessing behavioral health or supporting someone who needs access to behavioral health or providing behavioral health services, where it's just very uncommon that anyone has not seen any of these things happening. And we're all trying to make progress. I think there has been some progress made in this, but there's a lot more work to be done. And we're hoping that this training can kind of help diagnose some of those areas for improvement and help connect people with the resources that are out there to assist. Just as a quick agenda, we'll start off with a little bit about RIPEN, the Rhode Island Parent Information Network, and RIREACH. That's the consumer assistance program that RIPEN operates for anyone having health insurance issues. We'll talk a little bit about the Mental Health Association of Rhode Island, the Rhode Island Parity Initiative. We'll talk about the main mental health parity laws, the federal and state parity laws, where those parity laws apply and to what plans. And then the two main sections of those laws that we see day to day, which are their restrictions on financial requirements and treatment limits, and on non-quantitative treatment limits. We'll talk a little bit about the work they do around transparency. Organizations like us and behavioral health providers and consumers can see the progress being made on rendering mental health and medical surgical health at parity with each other. We'll talk about denials and appeals, both the pathway that one can take individually and also some resources out there, including RIPEN and the RIREACH program for individuals who have been denied access to services or need help appealing. We'll talk about what to do if you suspect a parity violation. And then at the end, we'll touch a little bit on some COVID-19 related changes that have been around now for a little while, but that due to the pandemic have been put forward in regards to behavioral health coverage. So just to touch a little bit on the Rhode Island Parent Information Network, we are an organization founded 30 years ago now in 1991 by parents of children with disabilities. It's now a statewide nonprofit, serves tens of thousands of Rhode Islanders every year across a wide variety of programs, both with regard to education support for kids with special needs, and also with regard to healthcare support, both for kids with special needs and for the entire population of Rhode Island. We've got about 100 employees, just over 100 employees, about half stationed out in the community. In normal times right now, we're all stationed out in the community because we're all working from home still. And we're built on what we call the peer model, which is that more than half of our board and about 75% of our staff are parents of kids with special needs or are caregivers to someone with a special healthcare or educational need. And so we can really bring our own experiences to the table when we're providing support for Rhode Islanders looking for assistance. We operate a call center that's funded and supported by the Office of the Health Insurance Commissioner. And that call center is a live answer phone helpline. You can call in and talk to someone from 8 to 5, Monday through Friday. We pick up calls live. We provide help for any health insurance issue for anyone in Rhode Island. It doesn't have to be people with just Rhode Island specific insurance. You can have any form of insurance if you are a Rhode Islander and call us and get assistance. We work a little bit differently from a traditional call center in that once you're speaking to someone at Ripon, you work with them for the duration of your case and have a point of contact rather than just having to call back over and over again. And we've got a lot of expertise to help deal with insurance company denials, with eligibility issues, with options for uninsured individuals, assistance with resolving outstanding medical bills, and general health insurance literacy. And our number there is on the bottom. It's also on a lot of the other slides. Feel free to call us. Feel free to give our number out to anyone else that you know is having issues. It's 401-270-0101. And our call center is available in both English and Spanish. And with that, in 2020, we handled just over 30,000 calls from Rhode Islanders, served about 3,600 clients, covered 366 legislative and governmental referrals, had a 94% satisfaction rate. And over the last 3 years, we've saved about $3.9 million for consumers in outstanding healthcare costs, which we're quite proud of. With that, I'll turn it over to Karen to talk a little bit about the Mental Health Association of Rhode Island.
Thanks, Shamus. And I just want to emphasize, Shamus just talked about the consumer helpline, the health insurance consumer helpline at Ripon. That's one of a very important piece of information, because the fact is that for many people and providers, wrangling with the payer system, our health insurance payer system, can be very overwhelming. Especially if you get denied a service, a pre-authorization, or a denial for a service that's already been accessed. And so following with, by the end of this week, we're going to send out a packet of information, including materials that have that call center phone number on it, so that as a provider, as a community health worker or advocate, or as a patient, you can share that and use that. So we encourage that very much. The Mental Health Association has been around for more than 100 years. It was founded in 1916, and during its very long tenure has advocated for effective and compassionate care for those with mental illness and substance use disorders. Today, Mahari continues that fight for equity in coverage and effective statewide policies. Spent a lot of time at the State House doing public education. And as I stated earlier, in 2018, the organization developed the Rhode Island Parity Initiative. That initiative is really three-pronged. You can go to the next slide, Shamus. It is intended to, one, build public awareness about the fact that there are laws in place to protect those with behavioral health disorders, substance use disorders, from discrimination by insurers. The initiative tries to empower people with information about those laws and help people to assert their right to coverage. And so if nothing else from today, the most important thing for people to go away with is there are laws in place that mandate insurers provide coverage for mental health and substance use disorders at the same level, no more discriminatorily than they do physical health coverage. And there may be some, subtleties to that, but at its base, it's that. And if denied coverage, people should understand they have avenues for recourse. It's just like with any law. If we don't know it's there to protect us, how can we advocate for ourselves or our loved ones or our patients? And so helping people understand that is important. And this workshop is an example of the kinds of things we try to do. But we also work to improve parity protections. And that is through research. We have done every year, built on research that involves focus groups with patients and providers, that involves surveys in order to help determine what are the realities for people on the ground who are trying to find a provider, who are trying to use insurance coverage, trying to access services. So we do three things: research and policy advocacy, public education, and I should say research, advocacy, and public education are the three prongs of the Parity Initiative. So any questions, we have a terrific website with a whole slew of materials and resources, the findings of our research, and we encourage you to visit that at RIParity, www.riparity.org.
Thanks so much for that, Karen. We'll start now with just to make sure we're all on the same page as we're talking about the laws themselves, the quick little health insurance 101 with some key terms and concepts and facts about our health insurance market. Just to go through some common vocabulary, a deductible is the amount a client must pay first before their insurance company starts to pay. That could be $3,000 a year. There's high deductible plans that are much more than that. Some plans have still very low deductibles, but that's money that you're out of pocket before your insurance coverage really even starts to kick in. Sometimes you'll have preventive services. Well, you'll have preventive services. Sometimes you'll have just simple doctor's appointments that come in pre-deductible, but for most services, you have to pay that out of pocket first. A copay is just the amount that is paid by a client anytime she receives a service as a fixed fee. That could be $25 for a doctor's visit. Coinsurance is similar, but instead of a fixed amount like $25, it's a fixed percentage. So you'll pay 30% of the cost of inpatient surgery. Behavioral BH/SUD is just the acronym for behavioral health and substance use disorder. It's a term used to describe mental health services covered by the parity laws. It's kind of the specific legal term they use there. Self and fully insured plans. This is a little bit tricky, but it goes to the jurisdiction over specific health insurance plans. Those are the categories of employer-based insurance. Self-insured plans, those are usually larger employers, are not subject to state regulation. That's the most important thing here. There's a lot more information about that happy to share if people have specific questions. But generally, larger employers are usually self-insured. There's some smaller employers maybe as well. And then fully insured plans are subject to state regulation, but self-insured plans are not. We'll talk a little bit more about that in a moment. And we want to talk a little bit about where Rhode Islanders get their health insurance coverage. This pie chart is not 100% exact. It's based on information from a couple of years ago, but it shows about where the breakdown of health insurance coverage in Rhode Island happens. About 54% of Rhode Islanders have coverage through their employer. About 20% have coverage through Medicaid, another 15% through Medicare. The way that this kind of breaks down is this is based on their primary source of coverage. So there's plenty of people that have more than one of these. You can have Medicare and Medicaid at the same time. You can have employer-sponsored coverage and Medicaid, or employer-sponsored coverage and Medicare. But this just kind of shows where people get their primary coverage. HSRI Health Source Rhode Island is the state-based individual marketplace for folks that are not offered coverage through work, but whose income may make them or maybe too high to make them eligible for Medicaid. Folks can get their coverage through Health Source Rhode Island. That's about 3.3% of Rhode Islanders. Another 3.3% of Rhode Islanders have other coverage that can be veterans coverage or direct pay plans where you buy them directly from an insurer. In Rhode Island, the only insurer offering direct pay plans is Blue Cross. And then 4.3% of Rhode Islanders remain uninsured. That's still far too high in Ripen's personal opinion. We'd love to see more of those folks be brought into the health insurance market, either through making things more available, by rendering more subsidies, or by just outreach to those populations. But that is down from over 10% before the Affordable Care Act. So there have been important strides in getting more Rhode Islanders insured. We'll talk now a little bit about the main mental health parity laws. The two gentlemen here on this slide are Pete Domenici and Paul Wellstone, the co-writers, the co-sponsors of the main federal parity law. That's the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equality Act, MHPAEA. We generally just refer to it as the federal parity law. And that law states that for plans that elect to cover behavioral health and substance use disorder, it requires offering behavioral health and substance use disorder services at parity to medical and surgical benefits. We'll talk about what at parity means a little bit later on. But one important thing to note here is that it does not require plans to offer behavioral health and substance use disorder benefits. Now, down the road in the Affordable Care Act, there were requirements around that. There's plenty of other law out there that does make that requirement, but the federal parity law itself doesn't actually require coverage behavioral health and substance use disorder services. It simply states that plans that do cover them need to cover them at parity. The Rhode Island state parity law goes a little bit farther. We'll see in the next slide that it only applies to some plans, to fully insured plans in the employer market. But for impacted plans, it does add some requirements going beyond what the federal law requires. It does affirmatively require plans to cover behavioral health and substance use disorder benefits. It prohibits annual and lifetime dollar limits on behavioral health and substance use disorder services. Now, the Affordable Care Act prohibited annual and lifetime dollar limits on any services, but this earlier than that laid out a prohibition saying that you could not have an overall cap either every year or for the life of an individual of a total amount of services that would be covered by an insurance plan. And then for substance use disorder patients, it requires coverage of non-opioid pain treatments, including chiropractic, even where a plan may not otherwise cover those services. In 2018, there was an amendment to the Rhode Island state parity law that goes again beyond what the federal parity law requires, that states that counseling and medication management visits, essentially the bread and butter, the routine annual or the routine visits one would have with a therapist or another behavioral health specialist, would be treated as a primary care visit for cost sharing purposes. And we'll talk a little bit about how that works momentarily as well. So just to look back at the breakdown of Rhode Island's insurance market, you now see the employer-sponsored coverage section is split between self-insured and fully insured. There's about twice as many individuals in the self-insured market than in the fully insured market. No parity laws apply to Medicare or to Medicare Advantage plans. That's an important caveat, an important exclusion from the federal parity law. And state parity law as well does not apply to Medicare. Parity does apply to virtually all other types of insurance, but self-insured plans are exempt from state law altogether, so only the federal parity law applies to them. So if you look at the individuals with HSRI coverage, with Medicaid coverage, or with fully insured employer coverage, they're covered by both the state and the federal parity laws. Employer-sponsored self-insured coverage is only covered by the federal parity law. Medicare is not covered by any parity law, and obviously uninsured individuals are not covered by any parity law either. And as I think Karen mentioned in the chat, feel free to ask questions in the Q&A tab. Feel free to write any questions in the chat. Feel free to raise your hand if anyone has questions. Happy to talk through any of this a little bit more. I know insurance can get weedy very quickly, So we want to make sure that we're being as clear as possible without going too far into the depths of insurance world. And here's a breakdown of what we were just talking about. Federal and state of parity laws apply to the individual market, including Health Source Rhode Island, in the small group market and the large group market fully insured plans, and for Medicaid managed care plans, federal and state parity laws apply. I see that someone just asked about Medicaid. So for Medicaid managed care, which the vast majority of Rhode Islanders who are on Medicaid receive their Medicaid coverage through managed care, then federal and state parity laws will apply there. Only federal parity law applies in the self-insured market, which is about 375,000 Rhode Islanders. Medicare, which is about 200,000 Rhode Islanders, is totally exempt from parity, as is TRICARE, retiree-only plans. The Federal Employee Health Benefit Program is exempt from parity laws, but voluntarily follows parity, and state and local government employer plans can opt out. But so far, the Rhode Island State Employee Plan has not opted out. As for local plans, it could get a little more complicated by that. But, and I see.
Yeah, Ruth is asking about Medicaid fee-for-service as opposed to managed care, and
Sure.
whether parity laws apply there.
That's a good question. It's going to be a little bit tricky because some of the rules around parity laws are specific to the financial requirements around it, the copays, cost sharing, and everything like that. And obviously, Medicaid fee-for-service is not going to have those. To get more specifically into the non-quantitative treatment limitations, which we'll talk about momentarily, that's a bit more complicated. There are very few individuals in Rhode Island whose primary coverage is Medicaid fee-for-service, but for those individuals, access to coverage is extremely difficult. I don't have the answer off the top of my head as to which of the non-quantitative treatment limitation restrictions apply to Medicaid fee-for-service, but if we are seeing clients with that coverage, I would highly encourage them to reach out to Ripen. We'll do a much deeper dive and hopefully help them access the coverage that they may be excluded from. So hopefully that answers the question for now. And if we have cases where we're seeing that happen, we can absolutely do a deeper look into that.
I actually would like to, Shamus, if you prefer not to, let me know. Because we have a relatively small group of participants and attendees today, I'm wondering if I should just promote everybody to, and I have this option of promoting everybody to a panelist, which would mean you would be visible on screen, and you can mute and unmute yourself if you have a question as we go through this. It would mirror much more an in-person session. Is that okay with you, Shamus?
Yeah, it's fine.
Okay, so I'm going to do that. Why don't you continue it while I promote people? But you,
Sure.
Folks, attendees, you will see yourself being promoted to panelist, and you can stop your video sharing if you're in the midst of eating your lunch or whatever. But
all right. So we'll move on now to what the definition of parity really is. And it's relatively simple, but obviously, as anything in legalese is, it's considerably more complicated than that and how it's actually implemented. At its core, parity means that behavioral health and substance use disorder benefits cannot be more restrictive than other benefits provided in an insurance plan. And that's essentially defined as having three major components. The first is financial requirements. That states that copays, deductibles, coinsurance, annual dollar limits, lifetime dollar limits cannot be more onerous for behavioral health and substance use disorder as they are for other benefits. Take, for instance, you wouldn't be able to have a $30 copay for behavioral health primary care, but a $25 copay for medical primary care. Second is treatment limits. That's, for example, a capped number of visits per year. You wouldn't be able to say have an unlimited number of physical therapy treatment appointments, but limit someone to only 12 one-monthly behavioral health therapy appointments. And then the more complicated one is what's called non-quantitative treatment limitations, frequently abbreviated to NQTLs. Those are the sorts of things that don't have a number assigned to them, but are how access to treatment is limited. There's no, certainly not in the parity law and in general law, there's no rule saying you can't have these things. It's just they have to be administered to behavioral health treatment the same way they're administered to medical and surgical treatment. Those are things like medical necessity review. That's the method by which an insurance company determines whether a specific service is medically necessary or not. That could be things like drug formulary design, the number or categories of drugs that an insurance plan provides to its members through prescriptions. Fail first policies, the determination that a cheaper alternative needs to be taken before a more expensive one. Those aren't prohibited, but you can't just have them in behavioral health and substance use disorder benefits. And importantly, this is something we'll talk a little bit more about what's going on this year, but standards for provider network admission, including reimbursement rates. That means that an insurance company cannot systematically underpay their behavioral health and substance use disorder providers in a way that means that their network is not going to be adequate for its members. We'll take each of those briefly in turn, but we'll focus mostly on the non-quantitative treatment limitations because that's where most parity violations take place currently.
And it makes sense, right, Shamus? Because those are the ones that are a little easier to manipulate and harder to see on the part of patients and providers.
Absolutely, absolutely. So just to start briefly on financial requirements and quantitative treatment limits, as Karen said, these are not as common, but the way that one would potentially see that is a cost sharing or visit limit rule for behavioral health substance use disorder benefits that's more restrictive than rules for other benefits. As we see here in the box, that is specifically what is prohibited by the parity laws on financial requirements and quantitative treatment limits. You can't have a separate deductible for behavioral health and substance use disorder services. In the past, that was common. You would have your main plan deductible that applied to all your medical surgical services. But then if you wanted to get behavioral health and substance use disorder services, you had a separate deductible you had to fulfill. Sometimes that deductible was even higher than your main deductible. You can't have higher copays for behavioral health and substance use disorder services. As I said before, you can't have a $30 copay to see your therapist, but a $25 copay to see your PCP. That's just not permitted. You can't have a lower visit limit for behavioral health and substance use disorder services. If you have two essentially equivalent level services, one of which, let's say physical therapy, you allow 20 visits a year, but for behavioral health and substance use disorder services, you only allow 10 visits a year. That's not allowed. But as we said, clear violations here are rare. This is something that's really easy. Like right after these laws were passed, there was a lot of work that needed to be done. There were a lot of violations of these rules. But you can just simply look at a set of plan documents and see what your copays are. They give you that every year. Not everyone necessarily reads them, but they do issue you it every year. And you can see what your copays are for different levels of services, for your primary care, for your specialists. And if they were administering different copays there, you would see it right away. And so those sorts of violations have largely gone away. Really where the focus is on non-quantitative treatment limitations, because as Karen said, these are a little bit more ephemeral. It's kind of back of house stuff. Frequently, the insurance companies will say that it's protected information, that it's confidential because it's business plan stuff. And for that reason, it's a little bit more difficult to track down where exactly this happens. But essentially the rule is the same. Plans can't have more difficult or restrictive NQTLs, non-quantitative treatment limitations, for behavioral health or substance use disorder services than those they apply to other benefits. Like we said, these are things like what the plan considers medically necessary, the kinds of prescription drugs the plan covers, fail first or step therapy policies, how a plan builds its network of providers, including the reimbursement rates that it uses to attract providers to their network, and written treatment plan requirements. You can't have a policy in behavioral health and substance use disorder that you don't have in your medical and surgical, your non-behavioral health benefits, but you also can't administer these more onerously or more rigorously to behavioral health and substance use disorder than you do medical surgical. In way of a quick example, say, for instance, a plan requires prior authorization for behavioral health or substance use disorder therapy sessions, but allows physical therapy or occupational therapy without prior authorization. This, for instance, would be a violation of the restriction on NQTLs. But say a plan requires that individuals attempt treatment with cheaper generic drugs for both behavioral health, substance use disorder, and other services before more expensive name brands are provided. That's not necessarily a violation. It could become a violation if the policy by which they determine success is more onerously applied to behavioral health than it is to medical surgical, or it could very easily become a violation if they make you go through a much longer process of going through generic drugs, or if they don't even really administer that policy. And so that's why this is tricky. It's really difficult just to look at a policy and say whether or not it violates parity laws, because it's frequently how it's administered and how frequently it's administered. And so as people are seeing these sorts of things either happening to yourself or happening to clients you're working with, please feel free to reach out to Ripen. We can absolutely look into this, but because they are tricky, but there are rules that are allowed, and there's also plenty of things that are happening that are not. Another important part of the parity law is the efforts around transparency. For instance, medical necessity criteria must be provided to any current or potential enrollee in the plan or to a contracting provider upon request. This is already common. Blue Cross, for instance, has a list of all of their medical necessity criteria online, but it's not always as easy to find as you'd like. And it's also not necessarily easy to find the specific criteria that applies to a particular condition. Just because they have those criteria and just because they're listed doesn't mean that these are necessarily readable documents. A reason for denial must be stated on the denial document. You can't just have a denial notice come out saying that we're not going to cover XYZ service, because you need to have the specific reason. It has to quote, if it is a medical necessity denial, it has to quote the specific set of criteria they're using to make that determination, and it must be subject to appeal. And upon request from any member that has been denied, a plan must provide information relevant for an analysis of parity compliance, including information on the benefits that they're comparing it to and any non-quantitative treatment limitations.
So I want to interject here, if I can, Shamus, because I think this is a place where if you are, I know based on the people who are here today, we've got some community health workers, we've got some state agency staff, we've got some providers, and we have some patients. This is the screen that I think is really important, because I think the first, besides the issues that people have with our inadequate network of providers, meaning we don't have enough behavioral health providers that accept coverage, that for people to easily get care. Once someone is in treatment, whether that is, inpatient for substance use disorder, outpatient counseling, where they run up against problems as a patient is in this space. Most often we hear through our focus group work and the communications we get through the Parity Initiative. And so I think this is the point at which, because parity can be very confusing and hard to understand, that this is the point at which a provider or a patient or a community health worker assisting a patient could at least make an initial call to the plan, Blue Cross, neighborhood health plan, whoever the insurer is, and say, I got this letter of denial. What does it mean? And how does it reflect mental health parity law? Like, make that first call. Write down the date of your call, write down what you are told, hang up, and then call the Ripen call center. Because this stuff can be complex. And sometimes it's enough just to push back a little on the insurer to have it dealt with. Sometimes it's going to be much more significant work that needs to be done. And sometimes the issue can't be fixed. But make a call, write down that you made the call and who you spoke with, and if you can, what they said, and then hang up and call RIPEN and let them begin the process of helping you understand where you are and what needs to happen, and their expertise in helping you address that. Because some of this is really kind of over the top for all of us, even those of us who better understand these things. And so that's my advice. Call the insurer, mention mental health parity, write down what they have to say so you have a record of that call, and then call the RIPEN call center.
Yeah,
Right,
thanks
Shamus?
for that. I think that's great. And also don't hesitate to reverse a couple of those steps where feel free to call the RIPEN call center, and then we can make the call over to the insurance company with you if you feel like you need support for that conversation. These are frequently conversations where the first person that you're going to talk to at an insurance company call center is not necessarily going to be able to give you the full rundown of the non-quantitative treatment limitations that the plan administers and how that applies to your specific plan or to your specific denial. And it's frequently something that ends up getting escalated up a food chain where we then eventually get a response back. And RIPEN is more than happy to help kind of navigate that process because it can be somewhat arcane sometimes. But absolutely, absolutely, don't hesitate to call your insurance company on these sorts of cases. Don't just accept a denial as gospel. It's not infrequent that we see denial documents that don't satisfy these requirements. Sometimes the denial documents are much more broad than they should be, that they don't specifically state the medical criteria. And it's also not infrequent that we see medical necessity criteria being improperly administered. There's certainly plenty of times that we think the medical necessity criteria themselves are problematic, that they are in violation of parity, that they are stricter on behavioral health conditions than they are on medical surgical conditions. But even when they're not, even when the criteria themselves are fine, that doesn't mean that every time that the plan administers those criteria, they actually follow their own rules. Sometimes they deny things even though the criteria says that such and such a service should be covered. So call them out on it and call RIPEN, which we'll come back to
because
again.
I think what we have experienced and what we have heard from patients and providers both is that too many people just accept that first no as an answer. And that is where that is preventing people from getting well. And we don't want to see that happen. And so don't take no as an answer up front. Follow through, even if to the RIPEN call center, so they can hold your hand through the process or your patient's hand through the process. Because if we don't push, we don't make progress. And one person pushing can mean progress for 10 other people.
Very much so, very much so. So just to do a quick recap of what we've talked about so far on mental health parity laws, the central rule that both the federal and the state laws put forward is that plans can't treat behavioral health and substance use disorder benefits differently than other benefits, or at the very least, they can't treat them less favorably than other benefits. Health insurance is complicated. The analysis of whether something is or is not a parity violation can be difficult, but as Karen has said, call the RIPEN call center with any questions. Our team is happy to help. Our number's there again on the screen, 401-270-0101. We can help do a deeper investigation. We can work with our state partners. We can work directly with the insurance companies to determine whether something that is being done is potentially a violation of the parity laws, and help provide you with your options for pushing that forward if we determine that is the case. We'll talk a little bit about what the denial and appeal process looks like. But again, this is something that the RIPEN call center helps with. So feel free to just call us at any time and we can walk you through this again. Just about any decision can be appealed. It's almost always best to appeal in writing. Sometimes insurance companies will allow you to do appeals over the phone. The reason that we never suggest that is because if you appeal over the phone, you don't necessarily have a good record of exactly what was said and who said what. If you do it in writing, you know exactly what you're submitting. You just save a copy of it. You generally need good medical evidence and support for whatever condition or whatever service you're trying to access. If you're being denied access to a service, that can take the part of looking at the criteria themselves, the medical criteria that are being applied, and showing that you satisfy certain conditions. It can be letters from doctors. It can be articles from scholarly journals talking about why a specific service is beneficial for a specific condition. But it just needs to have a medical grounding, either in your specific chart or in the medical literature. The exact rules around appeals depend on the type of coverage. Some forms of coverage have short deadlines for appealing a denial of service. Other types of coverage have much longer deadlines. Sometimes the rules are different for if you're trying to access a service and have not been allowed to access it versus if you've already accessed a service and the plan has declined to pay for that service. But these are all rules that the Ripon Call Center can help you navigate. Don't feel like you need to sit there with your whole set of 100 pages of plan documents that you get from your insurance company and figure it out yourself. There are plenty of things out there to help you understand that. Some comments. Go ahead. Yeah.
I wanted to just quickly interject, and I think it's coming up, Shamus, in your presentation. But one place where a lot of people end up with a denial is because of the fact that they are forced to go out of network to find an adequate provider to meet their needs. So, you know, we have a limited number, not enough counselors and psychiatrists and psychologists that are in our state and in our state's insurance plan provider networks. And so a lot of people end up paying out of pocket to see someone because they're desperate. And then they try and get reimbursed for that out of pocket cost through their insurance. And I think that a lot of denials are happening in that regard. And I think, Shamus, you're going to be addressing that shortly, right?
We'll touch on it briefly, yes. But that's a good point, because a lot of these problems have kind of two solutions. And one solution is specific to the person who's experiencing the denial, and one solution is more general to the insurance system more largely. And we can definitely help on both of those. Obviously, the global solutions can be more difficult, but if you have to go out of network because there's no network providers, it's never a guarantee, but we can absolutely work with you to show that there were no accessible in-network providers for the condition you were trying to have treated. And if it's appropriate, go through the appeals process and obtain insurance coverage for that service. So don't feel like there's really any circumstance that is not worth calling Ripon about. We can always fight something and find out that the answer might be no, but it's better to have those fights and to take those fights time and time again to show that there is that absence in the network, that inadequacy in the network, than it is just to let those sorts of cases go. But yes, some common behavioral health and substance use disorder appeals issues include prior authorization denials. Just generally, you want access to a service and you're being told that it's not medically necessary. Medical necessity review, that's after you have a service, if it's not paid for because the insurance plan determines it wasn't medically necessary. Out of network or emergency balance bills. As Karen said, we can work to show that a network is not adequate and that you need to be able to see an out-of-network provider either before you see that provider or in some circumstances after you've already seen the provider and received the bill. Not all denials are parity issues. Some of these might not even be a parity issue. Sometimes it has nothing to do with the comparison between behavioral health and medical surgical benefits. But just because it's not a parity issue doesn't mean it's not an issue, doesn't mean it's not appealable. We certainly can work on any of these sorts of cases and provide guidance or go through the appeals process for denials that are inappropriate, whether or not they constitute a parity violation. The best way to start, if you are issued a denial, to determine what your rights are and what you should do, start by reading the written denial document, see why the claim was denied if it's identified, see what the deadline is for appealing. Deadline is often 180 days for the first level appeal, but it can be shorter with certain types of coverage. Most plans offer multiple levels of appeals. If you lose the first one, that doesn't necessarily mean it's the end of the road. You can sometimes appeal again, either inside the plan or outside of the plan. And as we've said multiple times, the iReach call center is a great resource for help with appeals. Never hesitate to reach out to us. The best recommendation I can give you is just call us pretty soon after you get the denial, because sometimes the biggest issue that we have is if someone calls us a year after they were denied access to a service, or a year after they received a bill for a service. Sometimes it's too late, not because the appeal is valid, not because the denial wasn't wrong, but simply because you only have a limited amount of time to work, and it takes us some time to actually build that case as well.
And I would interject as well that this is no small thing. For some people, these denials are in large amounts of money. You know, if it's for an inpatient treatment program, or, you know, a hospitalization or a weekly counseling visit, these dollars add up. And so, I mean, Shamus pointed out that the call center has saved patients millions of dollars over the past several years. When we think about that, it's important to understand that for many of us, these kinds of dollars can significantly impact our financial well-being as well as our health and emotional well-being. So it's important to take it seriously and pursue every avenue possible to address it. You know, if you've paid an extra $10 copay, all right, but when we're talking about $10,000 or more, it's significant.
Which we certainly see. Yeah. And additionally, if you suspect that you have seen a parity violation, there are various governmental regulatory agencies that have specific oversight over these parity laws. If your plan is part of the individual market or the fully insured group market, that's like a Health Source Rhode Island plan, a direct purchase Blue Cross plan, a smaller employer plan. Then the state Office of the Health Insurance Commissioner has oversight over that. The phone number is there for OHIC. For self-insured plans, that's federal law. That's the Employee Benefit Security Administration under the Department of Labor. Their number is also listed there. For Medicaid, it's the Executive Office of Health and Human Services. They don't have a specific contact for parity violations that's available to the public, but generally, I'm going to recommend just call us at Ripon. If you think you're seeing a parity violation, reach out to us. We can work with any of these insurers, both federally and state, to investigate the claim, help you file appeals if an appeal is appropriate, and route parity complaints correctly. With that, we'll move on a little bit to what's happening on the ground this year, kind of moving more to the overall system changes that we're pushing for. That includes the insurer market conduct exams that were released last year in 2020. All of the insurers that were covered were found to have violated parity requirements systematically in their plan documents, in the way they were administering these plans. And each of them was instructed to create a corrective action plan in concert with the Office of the Health Insurance Commissioner. We're waiting for issuance of that publicly to see what these insurers have to do on the ground to correct some of the parity violations that were found in the market conduct exams. The parity insurer, I guess I leave this to Karen.
Yeah, this is no small thing. The Office of Health Insurance Commissioner conducted market conduct exams on every single one of our state-based insurers. So Blue Cross Blue Shield, United, Neighborhood Health Plan, and Tufts, and found that each and every one of them, in looking at hundreds of patient claims, had violated federal and or state parity laws in their use of prior authorizations, in their determinations of medical necessity criteria, in those areas that Shamus articulated. So this is endemic. And we are anxiously awaiting these plans that are a roadmap for how insurer behavior in this regard should and is intended to be changed. And when we get that, we will incorporate that into these trainings. We will put out information to the public so that we can all help monitor, especially those of us who are, you know, helping bridge the gap for people in accessing care, to make sure we all understand and are monitoring for correction on these things. It's pretty significant. So.
And then some of the major proposals to move forward, and it says 2020, it should say 2021, include one major gap in the market conduct exams, which is that the market conduct exams did not look at reimbursement rates. And that is a clear gap in the provider networks and behavioral health. The providers that remain in the networks are under reimbursed. There's been plenty of studies that have shown that. And the provider networks are small because many providers just choose not to be in those provider networks. They choose only to see patients outside of the insurance system, where an individual has to pay out of pocket, and frequently at much higher rates than their copays would be within their insurance.
And the reason for that is because providers have a higher administrative bar, or have had a higher administrative bar in dealing with all of the prior authorization, phone calls and conversations, and medical necessity criteria. It's also harder for them to get credentialed in these insurance networks. And in return, they get reimbursed less, significantly less, 23% plus less than similar practitioners on the physical or surgical side of the spectrum. And so we believe that, one, these low reimbursement rates are a violation of parity as intended under the law, and two, they are a driving factor for our inadequate network, which is a barrier to people getting care. And so we're trying to fix that through legislation in the state's General Assembly.
Yeah. And another major legislative activity for the Parity Initiative this year is the codification of Affordable Care Act protections into Rhode Island state law. Now we know at this point, the new federal administration is not as openly hostile to the Affordable Care Act as the previous one. But at the same time, there are still ongoing court challenges. There's one at the Supreme Court currently. There's another one that's wending its way through the system. We know that the Affordable Care Act will not stop being attacked. And because of that, and because we know that these protections are so crucial to both health insurance consumers more generally, but specifically to behavioral health consumers, I mean, the Affordable Care Act did many things, including laying out essential health benefits that need to be covered, codifying preventive services that need to be provided free of charge, guaranteeing access to coverage, prohibiting annual and lifetime limits for coverage. All of these things are extremely important consumer protections that ensure people can actually access the behavioral health services they need. And if the Affordable Care Act were to go away, those protections would go away as well. We need to make sure those protections are established in Rhode Island state law to ensure that individuals can continue to benefit from their coverage, even if the federal Affordable Care Act goes away. We'll talk very briefly about some of the changes due to COVID-19. These were brand new when we did this presentation last year. Some of these have been baked into the system a little bit. There's been some changes, but some of this is kind of, it's still extremely important to knowing how during the pandemic and during this time where health coverage is being administered very differently, what those protections look like. And then I want to make sure we have some time for questions as well. There have been many changes due to COVID-19. Insurance rules are still evolving even a year plus after. They'll certainly continue to evolve as we make progress with the pandemic and out of the pandemic. But some important changes involving behavioral health include expanded access to telehealth, protections for Medicaid recipients, and access to insurance for people who lose coverage. There's plenty of other insurance changes out there. Ripon actually did a series of webinars on that, which if people are interested, you can check out our YouTube page. Some of those are listed there. But just to touch briefly on these three important ones, many forms of insurance now allow telephone-only telehealth for certain services, including Medicaid, fully insured commercial plans, and Medicare. This usually includes behavioral health therapy services. This is also an important legislative piece of legislation that's in the General Assembly right now to establish this more permanently. But at least for the time being, telephone-only telehealth is allowed federally. It did not used to be. And it's covered under most insurance plans in the state, if not all of them. Some other changes in the world of telehealth that are being looked at as part of the overall package of reinventing telehealth and ensuring that it's available both during and after the pandemic include reimbursement rate parity in behavioral health compared to other, ensuring that behavioral health services offered through telehealth are reimbursed at the same rate as they are in person to ensure that providers continue to make telehealth available to individuals who don't feel comfortable in person or for any variety of reasons cannot attend an in-person appointment. And some other major insurance changes that we think are important in the world of behavioral health is that Medicaid is suspending most terminations, recertifications, and renewals during the crisis. If you have Medicaid, you'll generally keep it unless you ask for it to stop or you move out of state. There have been some changes on this recently. We are seeing Medicaid terminations come in to Ripon. If you or someone that you're working with is either having their Medicaid terminated, has already had their Medicaid terminated, or is being threatened with Medicaid termination, please feel free to call the Ripon call center and we can look at whether or not that is appropriate. Generally, well, if you lose other coverage due to a move into Rhode Island, back from working elsewhere, from studying elsewhere, due to losing your job, you're eligible to enroll in Medicaid anytime. That's just a general rule. You can always apply for Medicaid at any time if your income makes you eligible for Medicaid. But you can also purchase a plan from HealthSource Rhode Island all the way through August 15th, as though open enrollment had continued. Plans for HealthSource can be subsidized. You'll pay a premium corresponding to your income, and those subsidies have increased due to the American Rescue Plan, where now individuals up to any income can be eligible for subsidies to ensure that their health insurance coverage is no more than a specific percentage of their income. If you have questions about those coverage options, like I said, call the Ripon call center, 401-270-0101. And here's a list of resources. And I guess with that, we can open it up if anyone has any additional questions, has anything that wasn't covered during this, that people have additional insight on or would like any clarification.
So maybe, Shamus, we can stop share so we can see each other in gallery view and have some dialogue if people are so inclined. There's a lot of confusing information, so please don't hesitate to ask a question. Hi, Wendy. Hi, Carolyn. Hi, Claudia. Hi, Jamie. And hi, Ruth. Nice to see you. And of course, this session has been recorded, so we will send a link to the recording as well as a copy of Shamus's presentation, as well as some materials, including a guide to accessing care that highlights opportunities for people to access culturally and linguistically diverse providers as best as possible in our limited system, along with some of our Parity Initiative materials and information that people should share as widely as possible. So is there anything people want to add? We encourage you to use the Ripon Call Center, and we encourage you to sign up for updates and action alerts at the Parity website, because as things change, for instance, when we get those corrective measure plans from the Office of Health Insurance Commissioner when new laws are passed, or if we're looking for people to weigh in with testimony to the General Assembly to help make change, you can get access to that information.
Ruth, did you have something you were gonna?
I just have a question.
Sure.
With respect to telehealth, if, let's say, during the pandemic, a lot of students, let's say, who were out of state, moved home, and if a individual was seeing a counselor out of state, the expanded insurance access for telehealth might, if let's say they were under age 26 and they're on their parents, so insurance, so maybe the insurance would cover it. However, am I correct that let's say the person's in California, if the therapist is not licensed in Rhode Island, then that is still a problem. And unlike some states, Rhode Island does not participate in I forget what it's called, but it's kind of across, I'm sorry, yes. And do we still not participate?
That's a great question for a couple of reasons. First off, at the beginning of the pandemic, a lot of the rules around that were not being particularly strictly enforced. That has changed. So at this point, take your example, a student studying at one of the University of California schools, for instance, who has a California-based mental health provider who is not Rhode Island licensed. That student is now studying remotely from Rhode Island. The location of a telehealth appointment is the location of the individual receiving the telehealth. So that's the student in this circumstance. So if they're in Rhode Island, that is a Rhode Island appointment. The California-based practitioner would need to be licensed in Rhode Island in order for that appointment to be permissible. There's two levels of concern there. First off, there's just the general licensing and practice rules. And then separately, there's the health insurance reimbursement. That is a health insurance reimbursed appointment. If it's being done by someone outside of the practice locations, then it's not going to be paid for. And you're right in that Rhode Island is not currently a member of the Interstate Compact that allows individuals to practice across state lines. The Department of Health had modified their credentialing criteria, so an individual, a practitioner like that could go through a more expedited pathway to get licensing in Rhode Island during the pandemic. But again, that is also, that relaxation is starting to go away for certain provider types. There were emergency 90-day permits, essentially licenses that allowed folks to practice under a very wide variety of practice areas. That variety has been limited somewhat. And so at this point, for many practice areas, you essentially have to go through the entire process of being licensed in the state of Rhode Island if you want to see telehealth patients in Rhode Island. That's a broader issue for a number of reasons. There's the Interstate Compact that obviates some of those issues, but there's also a variety of insurance rules at the federal level that define the location of a telehealth appointment as where the patient is, and doesn't really make a lot of sense in a market where people are getting coverage through telehealth across state lines. But certainly something that's worth monitoring, that there's work being done on the Rhode Island level to engage, to sign those interstate compacts in the General Assembly this year, and also work being done on the federal level to kind of modernize the way that we look at telehealth rather than the way that it's currently constituted, which is essentially no different from an in-person appointment.
Okay, thank you.
Any other questions? Again, as I said, the most important thing is there are laws in place, federal and state, to protect patients. it's complicated. If someone is denied or having trouble getting coverage for their behavioral health care, call right. It's the best message, especially for patients in the midst of a crisis. It's the
And this is a
best.
lot to think about too. And so if people have questions that come to you later on, you'll have Karen's information. I think mine is in the slide deck as well. Feel free to reach out to either of us with
Yeah.
questions that arise down the road.
And if you have thoughts about groups that would be interested in a training of this kind, let us know. We'd be happy to facilitate for other groups and for targeted groups of people as well. So we're happy to hear and connect on that as well.
Can I just say, I've heard this presentation in different forms many times, and every time I learn something new.
Mhm.
And it's clear, it's great. Thank you.
Thanks for coming. Glad that is helpful.
Yeah, it's not the most exciting topic, but it's a very important one.
Very
So.
It's funny, I think it is.
So, all right. Well, we thank everybody. Thank you, Shamus.
Thank you so much for everything.
Thank you all.
Thank you, Claudia. And we shall see. Thanks, Claudia. And we shall see people at our next. We're having a session on Friday with the Health Insurance Commissioner, asking him some specific questions. So please join us for that. You can find that information up on the Mental Health Association website or Facebook page. And we encourage you to keep learning, keep engaging.